All right, let's get this started. Good afternoon, everybody. I am Summer Gathercole. I'm the Managing Director of SHG Advisors, and we are the firm that is bringing you the LIFT Academy, which stands for Learning Initiative for Fighting Homelessness Together. We're delighted to have so many of you here, and this is our first virtual assembly. So every month for the next year, we will have at least one virtual assembly or one learning circle, and we'll talk to you a little bit more about what that is here in a minute. But today's virtual assembly is focused on the intersection of Medicaid and homelessness. And the reason that we are starting with this is because many of you attended our kickoff, our liftoff event on May 20th. And the number one request that we got coming out of that event was to learn more about Medicaid. What does it mean? How do you build it? How do we integrate it into our work? And so that is really why we're excited to kick off this virtual assembly series with Medicaid. So very excited to be here with all of you. A couple of just housekeeping items. Everyone is muted upon entry, and as I'm sure you all know, that's just to help eliminate some of the background noise. Definitely want to encourage people to put your questions in the chat box. We will be monitoring the chat throughout the event today and making sure if we've got time to address those questions. And then just a reminder as well that this is being recorded, and we will go ahead and post the recording on our resource page here in the next day or so. I want to ask and encourage everyone to add your name and affiliation in the chat box just so that everyone has a sense of who's with us today and who's joining. Just to give you a sense of what to expect, obviously we're in the welcome portion of today's event. We're going to talk a little bit about the history of Medicaid policy, and I should say our friends at Healthcare Policy and Financing are going to be talking about the history of Medicaid policy, how to engage with Medicaid, kind of walk through a couple of scenarios that will be relevant for all of you, and do some Q&A, and then talk about what to expect coming up. So just a quick reminder for those of you who maybe didn't get a chance to attend the May 20th Liftoff event. The LIFT Academy is a 16-month program that's really geared towards those organizations that are addressing homelessness and their communities who have received transformational homelessness response grants from the Department of Local Affairs and Division of Housing. So most of the work between now and then will really be focused on these virtual assemblies, which are kind of larger webinar style formats where we kind of bring you broad topics to talk through. And then we also have learning circles, and those are some more kind of intimate, smaller, much more focused conversations. And the example that I always like to use is rapid rehousing is a great example of what could be a learning circle to kind of bring that group together of people who are doing rapid rehousing and learn from each other. This, of course, is open to all of the Thor grantees across Colorado. For the virtual assemblies in particular, there's no limit. So we always encourage you to invite your colleagues from your organization to these events. And also want to welcome some of our emerging communities that might be joining us today. There were a number of obviously 64 recipients that received Thor grants across the state. And then we are starting to work with a handful of new communities across the state that are just beginning their journey to address homelessness in their communities. For those of you who were also at the May 20th event, just a reminder that all of our work within the LIFT Academy is really focused on these three pillars. So funding, sustainability, intentional inputs, and programmatic excellence. We heard a lot about that at the Liftoff event, so we're not going to spend a lot of time on that now, just because we really want to get into the meat of the conversation. But obviously today is really about that funding sustainability piece and understanding how Medicaid plays a role in housing and homelessness. And I just want to encourage everyone to visit the resource page. That is where we will be listing out our upcoming virtual assemblies, our learning circles. That is also where we will be posting the recording from today's event. And just want to encourage you to bookmark it, keep an eye on it, keep going back. We have a couple of new sessions coming up that we're planning to post over the weekend. So I encourage you to check in on the site on Monday and see what we've got so you can start registering for what is coming up next. So with that, I am very excited to introduce Kristen Bates, who is the Deputy Medicaid Director and the Director of Office of Medicaid and CHIP Behavioral Health Initiatives and Coverage within the Colorado Department of Healthcare Policy and Financing. Kristen is probably one of the people in Colorado that is most passionate about behavioral health. She's joined by several of her team members who have really been involved in that intersection of kind of behavioral health and housing and homelessness and Medicaid, of course. So really delighted to have all of you here today. So thank you. Kristen, I will hand it over to you and switch over to your slides.
Thank you so much, Summer. And thank you all for having me. I'm excited to talk to you not just about how Medicaid is important for sustainable funding, but how Medicaid is also one of the ways we achieve equity and support for people who are unhoused. So that's what I'm going to talk a little bit about, like the history of Medicaid, serving vulnerable populations, how Medicaid has been able to help fill gaps in not just funding, but also quality. And I would say, oversight care, providing oversight of care. And then I'm going to talk a little bit about some foundational Medicaid policies that don't always show up when you're looking at like, oh, how do I bill for housing services in Medicaid? You're not going to see some of the foundational policies that I'm going to talk about. So I'm going to make sure you know, like in every time we bill Medicaid, every provider has to do the following things so that you have a better understanding of that. So we can go to the next slide. And what else can I say? I've worked in nonprofits for a long time, did a ton of grant work before I started working for the state and after. I worked for what's now the BHA for a while, and I've been at Medicaid about 5 years running our behavioral health office and benefits. So one of the big things that's happened in the past few years is since about 2019, there was a behavioral health task force in Colorado, and we've been really working to modernize our behavioral health system. And even though all of us recognize that behavioral health and health-related social needs and housing are separate, really separate areas of interest and separate and distinct ways that people experience this world, a lot of times these things get put together. And I think part of that is because people see kind of some of these social supports and wraparound services and behavioral health all coming together. I will say the other reason is I always make a really clear distinction from a stigma perspective, which is that while only about 25% of people become unhoused due to an issue with addiction or mental health, after being unhoused, everybody has behavioral health needs. It's a traumatizing experience. It's by nature, and it's incredibly impactful to a person's well-being and physical health, but also their long-term mental health. So the other thing I like about this, I don't like it when people are like, oh, people who are unhoused, it's because they're sick, it's because they're using drugs or alcohol, it's because they're, they're unmedicated. That's really not the case. We work with those folks, but long-term chronic addiction, long-term serious mental illness, being unhoused, criminal justice interactions, all of these things are criminalized in our communities. And a lot of these people are the same populations that we're serving. So I am more than happy to be the behavioral health person that also is fortunate enough to be the housing person who does a lot of our housing work here at Medicaid. Next slide, along with my amazing team. A little bit of history on Medicaid and serving vulnerable populations, again, very much from this behavioral health lens, from mental health, thinking about mental health and addiction and substance use. Really, you saw this space in which early on in the American healthcare system and the criminal justice system, you see people, either only very wealthy people or very poor people, get these services, and they're mostly happening in institutions. we had, again, this overlap between criminal justice and wellness and need and poverty and lack of medications. And in 1950, we finally have some antipsychotics that help people live and thrive in their communities if they're able to have access to these medications. We work on deinstitutionalizing the United States. We try to shut down some of these really harmful institutions where people were spending their entire lives, many of whom were not being well cared for. And it happened to be that in 1965, Medicaid was created, as well as Medicare. Through the Social Security. These things were created in 1965. And one of the things they tried to do in Medicaid was say, hey, listen, we are so about getting this into community care. We want communities doing the care. We don't want to do this institutionalization approach. History of Colorado Mental Health Institute at Pueblo used to have 6,000 people that lived there. They were a fully operational city. We want to walk away from institutions treating people badly, keeping them away from their families, and really not getting them well. And we want to really support the community. So we're not going to pay for inpatient services outside of a general hospital. We're not going to pay for inpatient services for mental health, for substance use. We're not going to pay for inpatient services in these circumstances. We're going to say, no, we're going to do this the community way. Well, what happens is there are people who, even if they have access to their medications, even if they don't have a behavioral health disorder, but specifically people with mental health and substance use issues, even if they're doing really well, even if they have access to a strong continuum of care, intermittently they might need services inside of a hospital. So you see this really well-intentioned goal leading to some issues where you see these things where people are going in and out of the emergency department. 1995, for those of you who are alive before then, like me, this was a big deal when this bill was passed, where all of a sudden emergency departments had to start serving people. And the reason this was created because people were having babies and dying on their front steps after being denied for lack of insurance. And this allows for a whole new level of access, but also, I would argue, the wrong kind of access for a lot of people who have chronic, ongoing social determinants of health that aren't working for them, as well as behavioral health needs. Simultaneously, during this whole process, criminal justice and law enforcement, they're happy to take these folks, right? These folks are getting arrested. They're going to jail. We create, 3 strikes laws. They're going to prison for being poor, for being sick. And around 2010, when we started having the expansion of Medicaid through the Affordable Care Act, we saw expansion for coverage, not just for your traditional Medicaid populations, which were people with disabilities, children, and people who were having babies. We started to see a lot of these people, individual adults who didn't have dependent children, suddenly could get Medicaid. In 2020, on and on, there's the last few years, we've started to get more and more services that cover peers, wraparound, mental health. Substance use wasn't even covered for a long time. And so you see this going from a system in which I don't know what you all would be doing in any of these times, but I'll tell you what, most likely if you weren't doing what you're doing now, if you were the same person, you might be running some other barely funded social program that was living off grants, church funds, shoestrings, sellotape, and doing things because the system wasn't built for the people that we serve, right? These people were going to the ER, into the jails, not getting care, not getting taken care of. So there's a reason why we have this historical underfunding of the behavioral health system. This is some of the policy reasons why, in addition to all kinds of things like stigma. We can go to the next slide. So the thing about it is that when I think about Medicaid and behavioral health services, I think about some work that I've done working in soup kitchens and shelters and places that were run by philanthropy, and comparing that to working for large healthcare systems, working for mental health centers. And really, you see this like safety net growing in these physical health and behavioral health clinics, moving away from what used to be nurses off shift taking a van out to the park at night and helping these folks. No one else was there to help them. But the other thing that I really think about is all of the folks that we're talking about that are served, that are consistently, in many ways, socially and by infrastructure, punished for being poor, being sick, and a number of other things, being, non-English speaking, being a person of color. All of those things come together. And what we had created was this two-tier system in which people are not getting care with dignity. They're not getting quality care. They're getting whatever we could put together. So when I talk about moving from this more philanthropy grant-based model to Medicaid, it's not just about, it is about trying to make best use of dollars, but it's not just about putting everybody onto this tough system. It's also about making sure that we are getting individuals with complex needs quality health care, that they are integrated into our system, that when they come in to be screened and supported, that they're getting the care that they need. And so when it seems to be tough to walk away from a model that's like, hey, you guys have a lot of strict rules, you have a lot of limitations, I want you hopefully to remember how important it is and how meaningful it can be to have these gaps filled and not have to do this with philanthropy dollars or what's left over or couch cushion money, to be able to have sustainable funding, but also to have that quality oversight. So we can go to the next slide. This is a little bit more about the coverage. This is really how we're authorized to pay for things. We started paying for peers in about 2021 over at Medicaid. Then we got some of these federal relief funds in 2021 as well, where we started our pilot statewide supportive housing program, really just building on the work that you all have already been doing, and trying to see how does Medicaid fit in this space. We also had a special program that looked at how peers could be utilized in those spaces. We got some legislation passed, and then now we've got federal approval to start covering housing and housing related services. So we can go to the next slide. So here's a link that we can put in the thing for him. Thing for you all. We can go to the next slide. This is kind of our main behavioral health page. For anybody who has questions about what we cover and what that looks like in our billing manual, that page is a really great place to start. And maybe Amy or Jennifer can put it in the chat for us since I'm presenting. A reminder, what is it that Medicaid covers? We cover more than any other insurance provider, right? We cover inpatient, hospital, residential care. We cover outpatient, medication-assisted treatment, all types of therapy, high-intensity outpatient, 9 hours a week, 20 hours a week. We cover mobile services. We cover outreach. We cover case management, care management, screening, brief intervention, pre-tenancy, and now tenancy housing support services. So this is like, for a lot of commercial providers, they don't provide this whole set of services, or they'll do it in a limited way. We provide those services for all of our members. Next slide. So when you look at this grant-based model versus the Medicaid model, there are some pros and cons on each side. Grant-based models are 100% more flexible, right? They also make it easier to kind of like hire a grant person, as opposed to I'm trying to think of it, spreading the responsibility across your organization. You really have like, hey, go to your grant specialist. Teresa knows exactly what to do in this situation. So that can be really positive. I used to love a no-cost extension. Oh boy, did I love a no-cost extension where we didn't spend all of our money. We needed to have the program extend. Maybe we didn't get people hired in time, but we had more time to finish. And then we also, having run a number of grants as well, you have the ability to adjust your budget. Say, hey, listen, we ended up spending more on this than this, and we need to adjust. But the challenges are, you're always trying to rush after that next grant. Your programs are a lot of times very dependent on some of these grant programs. And I think one of the big ones that I find challenging is trying to fit your program into whatever the grant or philanthropist goal is. And yes, Sue, I will absolutely share the slide deck with you all. So it's kind of like the challenges of the grant are you get to be flexible and make it yours, but at a foundational level, as a housing organization, you might be applying for a grant that's actually a grant for specifically getting people access to Spanish speaking care, or you're trying to get people into your program and you have a grant that's based on housing for youth or housing for veterans or housing for seniors or housing for families. And you have to kind of adjust your program to whatever the grants available are able to pay for. With Medicaid, some of the benefits are that really sustainable funding, where all of the folks, and I think the number of people that qualify for these services who are unhoused, it's like 98% of people. And the people who don't qualify, mostly it's due to right now, we have a program called Covering All Coloradans. So your immigration status, if you're eligible for Medicaid, then regardless of your status, you're allowed to get Medicaid. We'll see. For now, that's a really great thing. But traditionally, that's where we had seen some gaps. The other nice thing about Medicaid is if you serve 50 clients, you get paid for 50 clients. But if you serve 200, you get paid for 200. The challenges at the bottom there is that your funding becomes based on your volume and encounters. So if you run a program that you need to keep open and no one shows up, or 5 people show up one day and 30 people show up the next day, you have to balance your budget across those numbers. And it can be difficult to pay somebody when you didn't get any kind of reimbursement that day. So, but we don't have a funding cap. So it's not like, hey, you used your $100,000 this year. Anybody who's eligible for Medicaid services that receives those services will be reimbursing for those services. And then I would also add the oversight really provides us with some great opportunity to make sure people are, again, served with dignity and at a standard of care that is not separate for people who are poor and sick and unhoused. We have care that meets the standard for all people who are getting care in that facility. Next slide. Summer said that there might be some questions about how Medicaid, like what's the role of the federal government, the state government, the county government? I'm going to try to keep this high level because I think a lot of the questions you all have are going to be covered by Jen and Amy. I'm going to try to wrap up in the next 5 minutes. So our federal partnership is really where a lot of the inflexibility, I would say, and a lot of the basic standards of Medicaid are created. So what they say is, listen, anytime that we spend $1 on Medicaid, we get a match from anywhere from 50% to 90%. So we get either for every $1 we spend, we get up to another dollar. We could get like almost $2. So this is really exciting because it really leverages our federal funds, and we're not always reliant on state dollars to run this program. Unlike Medicare, which is an entirely federally funded program, it's run entirely by the federal government. There are no state folks that do Medicare services. Medicaid, for people who are low income, is specific, is the one who gets that matched. So it's a joint federal state program, federal partnership. Now in Colorado, it's supervised by, every state has to have a single state Medicaid agency. That's HCPF in Colorado. So, but every Medicaid program is different. What's important is that we will have these flexibilities that we can do. There are some things that are optional, some things that are required. So every state creates a program that works for them. Like I said, here in Colorado, we have a pretty robust behavioral health benefit. Other people might have that benefit that's available to only people with serious mental illness, for example, and it won't be for all Medicaid members. There's a lot of ways that you can run a Medicaid program. But the main thing that the state does in Colorado is that we pay the claims, right? We have something called a state plan, which is, for any of you who have insurance, it's your benefit package. It says, here's all the things we pay for, and here's the circumstances under which we pay for them. And as long as we're meeting those federal requirements, the feds are the ones who say that is payment. If you pay it that way, in the way that we've agreed, and we have a contract in our state plan, then we will give you your match. Now, there are certain circumstances, like the Covering All Coloradans program, where it's entirely run by the state. And we use our Medicaid infrastructure to run a state-run program. But in almost every circumstance, the reason that we have to meet some of these standards is because the feds say that we have to, and because they have a responsibility to maintain their budget. And then finally, in Colorado, the counties are delegated a specific role, which is eligibility and enrollment. So the interesting thing about Jennifer, Amy, and I is we are definitely on the side of things where, like, once you're enrolled, talk to us about what services are provided. It's really the counties that are determining at this point of care, hi, my name is Kristen. I need to sign up for Medicaid. They're going to tell me if I am or am not eligible. They're going to manage that enrollment process. And that's really the role of that kind of local Medicaid partnership that you're going to see. On top of that, we also have something called the RAISE, which I'll talk about next. Go to the next slide. Some of our foundational policies that I mentioned is that these are some of the federal elements that are really important that people sometimes in this space specifically get hung up on. This is one, it's like there is no version of Medicaid where you are getting paid as a provider if you are not enrolled with Medicaid. You have to be enrolled. You have to enroll using our Medicaid program enrollment. So there's a provider portal. You go online. It says, Google HCPF, say, I want to become a provider, and it's going to walk you through that. Jennifer and Amy are going to help you understand what that looks like for housing providers specifically. But if you want to know, wait, couldn't I just get some funding from Medicaid to serve my Medicaid clients? Unfortunately, in some circumstances, fortunately in other ways, no, that is not an option. We do not have options to reimburse people for services if they are not an enrolled provider. The other thing about it is that all providers have to be treated equally based on a set of policies that are approved by the feds. So I can treat a hospital different than I treat a nursing home, different than I treat a primary care clinic, right? But I can't treat one primary care clinic differently than another primary care clinic. The provider type that they're going to talk to you about, your provider type, it is one of the key elements that determines what your Medicaid reimbursement policies look like. So that's why it's important to enroll with Medicaid, become a provider. Most people takes about 5 to 7 days to be enrolled. And so, but it depends. If you're new to this and this is a new space, it could take you longer. We have supports for that. We have a provider call center and we have some services. The other big thing that's going to be unique for you all is that providers must be licensed or supervised by a licensed practitioner. So what that means is at the bottom, you'll see all services must be medically necessary. People, gosh, before I got to Medicaid, I was like, what is medical necessity? It seems like you guys are making it up. It's not. It's a pretty standard definition. While we have a formal definition in our regs, it basically means any reasonable provider would agree this is a good idea. That's what it basically means. And when we say something is medically necessary, we mean it also helps people get better. So when we say you have to be licensed or overseen by a licensed provider, the point is that this is part of somebody's treatment plan. We all know what happens to unhoused people. They get very sick. They do not get their needs taken care of. All kinds of examples. So in a lot of cases, it's very easy it's not rocket science to say, hi, this client has basic mental health, substance use, or physical health needs. They are unhoused. Let's getting them housed as part of their treatment plan, because that's going to help get them better. So this is what we've recently been authorized to do, but it has to be part of the treatment of something related to their health. And this isn't just a social service, because everybody could benefit from certain things. Everybody could benefit, for example, from a housekeeping service, right? Anybody not want a housekeeping service? Sure. Everybody could benefit from some kind of like life skills organization. But medical necessity says we can only pay for that if it's directly related to your health and your health outcomes at Medicaid. And then the last thing is for behavioral health providers, you don't just have to enroll with Medicaid, you also have to enroll with a regional accountable entity, which is how we run our behavioral health programs. So we can go to the next slide. I don't know how many of you all have insurance through your work. My work gives me insurance. I have Kaiser Permanente. But then they don't do dental. They do my vision, but they don't do dental. So I have a separate card that's for Delta Dental. It's got a different policy number on it, and it's a different company that runs it. That's kind of how managed care works. What we do in most of Medicaid, which is in the physical health space, is Medicaid is the insurance company. You have a card, it says Health First Colorado, that's our public name. That's how you know you have Medicaid. When you're a provider, you bill HCPF, you bill Medicaid, HCPF pays you directly. We are the insurance company. For managed care, which is how 70% of Medicaid is operated in the country, what you do is you are a state entity, you pay a health plan to be your health plan. You pay them to administer the health insurance product, right? So this is like for behavioral health, well, you have one card that says, hey, this is my physical health card. This is how I get hospital care, physical health care. For mental health and substance use, you're going to have a different card, like your Delta Dental card. And that's going to say Colorado Access, CCHA, or Rocky Mountain Health Plans or Northeast Health Partners on it. So that's kind of how you see a managed care and fee for service. It's important to understand that because for a lot of your housing services, you're going to bill Medicaid, HCPF, but for your clinical mental health and substance use services, to the extent that you provide them, you will be instead billing the regional accountable entity, which is the behavioral health plan for Colorado. This is one of the ways Medicaid can be very complex, and we are here for it. You guys have a year of support. We will be here throughout, working with Summer to make sure that you have everything you need. But that is one of the key differences between the way that we pay for care. And I think, Summer, am I done? I think I'm passing it over at this point to Jen and Amy. And I think we're going to do some discussion and questions at the end. Thank you all for those foundational elements. I will pass it to Jen and be here for the questions at the end.
Thank you, Kristen. For those of you that I haven't met before, my name is Jennifer Holcomb. I am the Behavioral Health Benefits Section Manager, and joining me today to help answer questions and watching things in the chat is Amy Austin. There she is. And Amy Austin is a unit supervisor that many of you may know from her role and work with the Swishy pilot program that we did together. And Amy's unit oversees outpatient and lower intensity services, community-based provider work, such as the work that housing providers do. I will deviate for just 30 seconds from the presentation to share that immediately before coming to HCPF, which has been about 4 years ago almost now, I spent the 5 years prior to joining HCPF working specifically in the homeless space. So also happy to be here with you and support you all in any way we can in helping you make the transitions that Amy and I have made into understanding Medicaid and how you can use it. So let's go ahead to the next slide. There's a lot on this slide, and unfortunately, as Kristen said, there is a little bit of complexity to figuring out where you fit in. So for housing organizations, please bear with me, and I'm not going to read everything on every slide, but I do want to spend a little time on this one to help you all understand what might make sense for your organization. The first kind of decision point for you is with our 1115 health-related social needs demonstration waiver, that has opened up whole new avenues and opportunities for Medicaid to provide some reimbursement and coverage for certain housing-related services. So the first question is, might this apply to you? If you are a housing organization that is administering community access team vouchers, CAT vouchers, or Colorado Fostering Success, CFS vouchers, or Permanent Supportive Housing vouchers, PSH vouchers, then you may enroll with Medicaid, as we're going to talk about in a little bit, as a housing provider. And there are certain things that housing providers can do in Medicaid. If you are not a housing organization that is administering one of these voucher types, so that's the top pathway that we just talked about, then the bottom pathway, if you are not administering one of these voucher types, is a little bit different. And you may or may not be able to bill Medicaid. So the first option is, I don't deliver any healthcare services. I'm a housing provider and I don't deliver healthcare services, but I have a good working relationship with someone else, some other organization or providers that come to my organization that do deliver healthcare services. That's fantastic. That's good. Community support network, strongly encourage that. But as a housing provider, you do not need to enroll with Medicaid for those services to be billed for, because those partners that deliver those healthcare services are the ones that would bill Medicaid. If you are not a CAT, CFS, or PSH voucher administrator, but you employ people that deliver healthcare services, either behavioral health or physical health, then you can enroll with Medicaid and you can bill for the services that those employees deliver. You're not going to enroll as a housing provider. You're going to enroll as a different type of provider, but you could enroll and you could bill Medicaid. Or if you don't directly employ those healthcare providers, but you enter into a contract with a small company or an independent provider who's going to deliver those services, you also could choose to become a Medicaid provider and bill Medicaid for those services and then pay your contractor who actually comes in and does that work. So there are a couple of different pathways, and we're going to talk through each of these, but hopefully that gives you some context that there's a narrow set of housing voucher administrators that can directly, as a housing provider, now have a relationship with Medicaid as a housing provider. And that's what's new with our 1115 demonstration. Okay, next slide. So these are your three pathways. As I mentioned, partner with a Medicaid provider, employ and a clinician or healthcare, physical health provider, or subcontract. Let's talk about what each of these looks like. Next slide. If you partner with a Medicaid provider, that partnership means that individual is going to manage their own billing and also their own compliance responsibilities for what needs to be documented, how things get submitted, and so forth. This is the easiest relationship to have because there's really no administrative burden for you as a housing provider. You have clearly scoped what services you're delivering, what services they're delivering, what your relationship is, what information you can share with each other. I'm looking at the chat really quickly. Even though we also serve So let me come back. I'm looking at Matthew's comment in the chat asking about billing for housing services provided to vouchered clients. And we will talk about that. Hold that thought, Matthew, for a minute. It depends on the services you're delivering. So we'll get there. So if you partner with a Medicaid provider, that's the easiest path, but that does not create a revenue stream for you as a housing organization. It's a relationship and it's a service, but it is not a pathway for any type of revenue. Next slide. If you choose to employ clinical staff, licensed healthcare providers, which could be physical healthcare providers such as a nurse, an advanced practice nurse, even a physician, or it could be a behavioral health provider, a social worker, a therapist. If you enroll any of those types of licensed folks, if you employ any of those licensed folks, then you can enroll as the Medicaid provider, and those folks deliver services under either as their license permits or for unlicensed staff that may also work in your organization. A licensed supervisor oversees the work they're doing, and your organization, as a housing organization, can bill for the services, and depending on what type of service would direct what type of provider you enroll with Medicaid as. And that also defines what lists of specific services you would be able to deliver and then bill for. Examples that we have, this pathway is the most flexible as to what services you want to deliver. Examples that we have, if you were a supportive housing provider, you'd enroll as a provider type 89. If you have a behavioral health clinician or more than one that works with clients and you want to bill for those services, you would enroll as a provider type 89 or a provider type 77. If you are doing some physical health work and management or had someone that was doing some prescribing, then you might enroll as a provider type 16. So part of what Amy's team does and helps advise housing providers on is talk with you about what are the services you provide, what are the staff that you have, and what provider types you might want to consider. And then you would make that choice as to which provider type makes the most sense for you. Okay, next slide, your third option. Your third option, which is probably the most complex to manage, but it's allowable, is you could subcontract. You could say, well, we don't employ any clinicians, but we'd like to enter into a contract for 10 hours a week for a clinician to come and deliver these services. Unlike the partnership where the clinician would come, they would deliver the service, they would bill for the service. If they're a subcontractor, they come, they deliver the service on your behalf, you bill for the service, you're responsible for paying them, you're also responsible for submitting the bills and ensuring that you comply with Medicaid rules. So this is allowable, available, and an option, but it is probably the most challenging and the most complex. Okay, next slide. So let's talk a little more drilling down to the next level down, if you've figured out how you enroll and what provider type you want to be, let's talk about what the actual steps are to becoming that particular provider type. So in the behavioral health space, where much of the work that we do is focused, we recognize that about 80% of individuals, roughly between 80 and 90, according to most information that we've looked at, of individuals that are experiencing homelessness are also experiencing some type of behavioral health concern or issue. Oftentimes it can be the trauma related to being in a unhoused space or state. So there's a huge amount of overlap, but we also recognize that there's a portion of folks that do not have a behavioral health condition and may also be experiencing homelessness. So therefore, we recognize that oftentimes, and you see us talk about the behavioral health clinical aspects a lot, but we do want to call out that it's not always behavioral health. And if you provide services for physical health needs, that is allowable as well and would be similar without the added layer of the managed care that Kristen was talking about. So when we think about behavioral health services and those clinicians, we think about a process where the organization or the individual practitioner gets credentialed through the Behavioral Health Administration or the BHA in many cases. And they may become a behavioral health practice group. They may be an SUD provider. There are lots of options, but they get that licensing if it's necessary. If it's an individual practitioner, they may not need that. They may just have their license from DORA and be an individual practitioner. But once they have their license, then they can enroll with Medicaid as a practitioner, or the organization that employs them can enroll with Medicaid as a provider and list that licensed clinician as part of their organization. And that happens through our Medicaid provider web portal. Then, after you're now officially enrolled with Medicaid, if you are delivering behavioral health services, you then need to contract and provide all your credentialing information to show that you have liability insurance, to show that you have a valid license, to show that you meet all the standards of being a clinician. That's what the credentialing part is. You provide all of that to the regional accountable entity, which is going to be the area, the region in the state where you're wanting to work. And through that process, that's how you get set up to then be able to treat Medicaid members and be reimbursed through that regional accountable entity. Okay, next slide. For those of you that are more visual, this is essentially what we were just talking about. With the Behavioral Health Administration, there are a variety of different license types that you may, as a facility, you may obtain. The most common and the broadest is a BHE license, a Behavioral Health Entity license. There is also a RSSO, Recovery Support Services Organization license. Those are peer-run, peer-led organizations. And then if you are doing any medication-assisted treatment work, you would potentially look at getting a controlled substance license as well. If you were working specifically with children, I don't know if we have any adolescent homeless program providers on today. But if you were working in a youth population, then your facility is also going to be licensed and credentialed, for example, through additional requirements that are in place for youth. And then, of course, everyone who is a practitioner that is individually licensed as a licensed practitioner of the healing arts is the official Medicaid term. This means you have a DORA issued license. Could be a licensed addiction counselor, could be a social worker, could be a nurse, could be a physician assistant, could be a doctor. Okay, get your license. Next slide. Enroll with Medicaid, and this is a screenshot, and you will get the slide decks. You will also have these working links at the bottom that show you what the enrollment portal looks like. And on the left-hand side, the first part is if you were to follow that link, you look at the list of here are all the provider types, and you look, and we gave you some examples of provider types that we think would be most common for you to use. But there's a list, and you read what each provider type does, and you choose the provider type you want to become with Medicaid. And then on the right, the link you see of the provider enrollment resources is where you go to get all the instruction and guidance on how to fill out the form. This is an example of what the form looks like, and you go through and you fill out your online application. For speed and efficiency, have all of your licenses in front of you if you're a licensed person, have your insurance in front of you, have all that with you because you're going to be asked to put in all that information as part of the process. Next slide. Step 3, this is outreaching the RAIs, the regional accountable entities. And you also see links embedded on this slide because on the left-hand side, the ACC provider resource link, if you're not familiar with the Accountable Care Collaborative, that's our sister office that oversees the RAI contracts and lays out what providers should expect when working with a RAI. So that's a great source of information if you're new to this space. And then the RAI contact information, the link on the right-hand side of this slide, is the place where you can click and say, oh, this is where I'm located. Who am I supposed to reach out to in RAI 1 to get this process started? And it identifies your contacts for each of the RAIs. Okay, next slide. This is the deepest level, so let's go ahead okay, so I've figured out how I want to engage with Medicaid. I've figured out how to enroll. I'm contracted if I need to be. Now I'm ready to bill. What do I do? Well, there are 2 ways, as Kristen also alluded to, there are 2 ways that Medicaid gets billed. One is called fee for service, or FFS, and fee for service is the way that all the physical claims work. Individual provider fills out a claim, it gets submitted directly to Medicaid. Medicaid publishes fee schedules on the main Medicaid webpage. So you know, if I delivered this service in this code, this is what Medicaid's going to reimburse me. Very transparent, very public, posted on the webpage. You fill out your claim form, you submit it to Medicaid, gets reviewed, claim is paid. That usually happens within a week, within a matter of days. Quick process. If you are enrolled as a supportive housing provider because you are administering PSH vouchers, CAT vouchers, CFS vouchers, then you are a provider type 89. And for the set of supportive services, that you deliver under the 1115, you will use this fee-for-service model. You will bill Medicaid directly. We have two codes. We have a monthly code, and we have a daily code, and you bill the code and receive your reimbursements directly from Medicaid. If you are employing a physical health care provider, like a nurse or a doctor, who's doing physical health things, checking weights, checking blood pressures, administering medication-assisted treatment, those things would also be billed in the same way through fee-for-service, directly to Medicaid, based on your provider type, directly reimbursed from Medicaid. If you are providing behavioral health services, you'd go through the process we talked about. You'd contract with a RAE. When you fill out a claim form, each RAE gives you all the information of how to submit claims to them. You wouldn't submit directly to Medicaid. You would submit your claims to the RAE. Part of the contract process is you negotiating your reimbursement rate with the RAE. So you have a contract with the RAE that says, and the RAE says in their contract, we will reimburse you if you deliver any of this list of services. Here's the rate we reimburse you for each of these services that you're contracted to deliver. And that is your guide. You fill out the same claim form, but you submit it to the RAE. The RAE is responsible for making the payments to you. Okay, in a nutshell, that's how billing works. Next slide. This is the claim form. When you heard me saying you fill out a claim, there's an electronic version. This is for anyone. The electronic version looks a lot like the old paper version. This is what the old paper version looks like. And that claim form, you provide a bunch of information using a CMS 1500 claim form. And that's the process, whether you're doing the claim through fee-for-service or through managed care, you essentially submit this claims information. So let's talk about what goes on that form. Next slide. Key questions. You need to identify who gets the service, who provides the service. And when we talk about who provides the service, there are a couple of fields on that form. The billing provider is the organization, the facility, or it could be the individual if it's an individual practitioner, but it's the billing entity that goes in the billing field. Who's responsible for that administrative billing part? Then there's a field that asks for a rendering provider. That is always the licensed person. Even if you have unlicensed staff that deliver services, their name never appears on a claim form. Their name appears in your notes. Their name appears in documentation where they're saying what they did. But this is why you need someone with a license that's overseeing that those services that were delivered are aligned with what's in the treatment plan, are appropriate for that member, and that rendering provider who's a licensed practitioner, their name appears on the claim. So you have the billing provider on the claim and you have the rendering provider on the claim. What services provided is actually where you list by code each billable service that you're allowed to deliver based on your enrollment type. So different enrollment types have different services. If you're a licensed clinical social worker, you couldn't bill for giving someone a shot because the code for that shot isn't a code that's allowed under your license. If you're a nurse and you administer a shot, you can bill for that. It's allowed under your license. So your enrollment type and your individual license type dictate what codes you can bill for. And the code is the what gets delivered. And then the place of service, which is another field on the claim, is the where that service is being delivered. So that could be in an office, that could be in a member's home, that could be in the community. So sometimes you're meeting with people in a public place, in a coffee shop, on the street, in a shelter, can be in the community. So you also indicate where you are delivering that service, and if a service is delivered by telehealth, you indicate that as well. Okay, next slide. This is showing you where some of that information goes on the claim and distinguishing between the who is responsible for the service and who is billing for that service. Responsible is your rendering provider. Facility or organization is your billing provider. Next slide. Okay. Before we jump into a couple of scenarios and get some feedback from you all, does anybody have any questions? Because that was a lot of information.
Jennifer, can I check in with
Yes.
Matthew Wood just to see if his question that was in the chat box has been answered?
Yeah, yeah. And so Zach has been very kind and tried to explain this to me multiple times, and I think it's a matter of me just not wanting to accept information. So I will say that. But I guess where I get confused is if we're saying that if you're not a PSH voucher provider, you can bill for supportive housing services if you have a behavioral health provider. That's where I get confused because our organization has multiple behavioral health providers, but I feel like we're being told, but we can't bill for our case management for supportive housing outside of our vouchered clients. And that's always kind of confused me. And again, I think Zach has tried to explain this to me multiple times, but I just remain a little bit confused, and I apologize.
I need to apologize. I think it is very complicated stuff, and there's a lot of nuance, and there's a huge amount of overlap. So when we were talking about that part of like, what type of provider would you be? You have to be a PSH voucher administrator to enroll as a PSH housing provider. And I put that whole thing in air quotes if you can see me, because our 1115 demonstration says PSH voucher administrators can do a bunch of things. That includes case management. Doesn't mean those are the only people that case manage, because for all of our people that are housed that have behavioral health support, many of them have case management support. So case management is not in and of itself a housing service. If you are a PSH administrator or a CAT voucher administrator or a CFS voucher administrator, then part of the package that comes with being that type of voucher administrator means that you can enroll as a specific provider type, that ED9 with a specialty type, that says, okay, what does this get me? Well, that gets you the ability to bill for housing navigation services, targeted case management for individuals experiencing homelessness. That's set. You can bill under that provider type 89. If you are not a PSH provider, but you employ behavioral health clinicians, then depending on the number of clinicians, that's the scenarios that you saw me talking through. You could be a behavioral health practice group. You could enter into a subcontract agreement. So there are other ways, if you have that staff and they deliver clinical services, as well as case management services, that you could bill for those services. Does that get at it?
Kind of. I think it's because we're in a middle place, and maybe we can set up some time off this meeting because I don't want to take up too much time. But I
Sure.
think it's the idea that we need to go two routes. One route for our vouchered clients so that we can bill for supportive housing for our vouchered clients. And then our other route, because myself and another behavioral health clinician work with our clients, we could bill for supportive housing services for our non-vouchered clients. That's
You
my
would
question.
not you would not bill supportive housing services. You'd bill clinical services. If you're a clinician and you're providing case management or therapy or other support as a clinician, you would bill for those as behavioral health services.
But
This,
we already do that, and we're successful at that.
Mhm.
We get our claims paid for our
Yeah.
therapeutic services. That took a while, but we figured it out. But I guess so. What you're saying is we can't bill for our case managers who do a lot of support in housing services. We can only do that for voucher clients. That's where I get confused, all. It doesn't
so
make sense to me, but
some of it is probably terminology. Uh,
okay.
Case management can be billed as behavioral health. Supportive housing can only be billed as supportive housing. So we can talk about the terminology, but when you
Yeah,
say that it's supportive housing, that makes it housing. When you say it's case management, it's different.
that's true. I see what you're saying. Okay.
And I think it
Yeah.
may help to think of members with a permanent supportive housing voucher are eligible for additional services that can be billed to Medicaid, like over and above the
Yeah.
basic coverage of behavioral health services for all members.
And I think
Thank
that
you.
there's a chat in here that is, if I could just jump in, that Amber highlighted. What's important is, the difference is kind of like what makes something medically necessary, right? So we said before, your medical necessity is required all the time. So for those housing services, basically you're like, okay, you have to meet these certain criteria. If you do, then you get those services. But for behavioral health, what makes it medically necessary is that it's part of a treatment plan. So in the chat, Amber highlighted that if you don't have a diagnosis or treatment plan with so you're not receiving clinical services, you can't, an individual, a provider can't provide somebody billable case management services unless it's part of their treatment plan, right? And so I think that that's a big part of it. Our billing manual helps explain, and I think Jen and Amy are going to go through some examples so you can see, but I think that that's a big part of it because really what you're looking at is if you're setting up a table at the mission and you're helping people get housed, but you don't have any information on them, you don't have a diagnosis, and they're not getting clinical services, those are the types of services that are unlikely to be covered. Whereas if as part of their clinical, like, they've done an intake, you have their information, you can bill for those services. That's the type of case management that's supervised by the clinician. I hope I didn't make it worse. I'm going to pass it to Jennifer and Amy to walk through some examples.
Amy, do you want to walk through some scenarios?
Sure. Yeah, I'm happy to do that. So we came up with 3 scenarios to kind of talk about instances you might experience in serving members and which of these scenarios might include services that are billable to Medicaid. So the first scenario, someone named Bertha is not a Medicaid member, but your organization is helping them apply for Medicaid through the Peak Pro portal. The question is that time spent assisting Bertha with getting enrolled billable to Medicaid? The answer is no. Time that is spent applying for Medicaid is not a billable service. But once a member is enrolled with Medicaid, there may be opportunity for services that you are delivering to be billable. So scenario 2, another person named Bernie is confirmed to be a Medicaid member. You help them complete an HMIS application because they are seeking permanent supportive housing services. Is this service billable to Medicaid? So, if your organization is enrolled as a permanent supportive housing provider, then this time would be covered as part of pre-tenancy services, helping a member to seek and those permanent supportive housing services. I guess I can pause. Any questions on those first two scenarios? Okay, we'll go into question or scenario 3, and then we can have some more time as well. So scenario 3 is another individual named Bert is approved for a permanent supportive housing voucher, and you meet with him weekly to complete applications and find housing. Is this a billable service? Yes, this is a billable service, again, as part of those pre-tenancy services that can be billed by organizations enrolled as a supportive housing provider. Any questions about any of these scenarios? I have a question in the chat about the specific rate for these services. So as we have transitioned the reimbursement for our supportive housing services to the fee-for-service model, we do have rates for these services. I don't have them off the top of my head, but any organization that is enrolled as a supportive housing provider does have access to the rates that are published on the fee-for-service fee schedule. Let's see, some additional questions in the chat. Paul asked, would that include providers that provide the tenancy support but are not the voucher administrator? So the pre-tenancy and tenancy sustaining services for members eligible for permanent supportive housing, those services can be billed by agencies enrolled with Medicaid as a supportive housing provider. And we have partnered with DOLA's Division of Housing, who is giving approval to organizations who oversee an allocation of vouchers and deliver services for members in permanent supportive housing. And so the first step towards enrolling with Medicaid as that provider type is to get that approval letter with DOLA. And I believe Zach Schaffner with DOLA is on this call. Zach, if you want to put that approval letter request form into the chat, that would be super helpful. And you can always reach out to Zach. I'm going to volunteer you for organizations that have questions about whether or not your agency meets that definition of a supportive housing provider.
Hey, Amy, can I jump in for a second? Just because I saw that Zach had his hand up. So Zach, did you want to chime in?
Sorry. Yes, I do. Thank you so much, Summer. So I just wanted to add that that Type 89 certification process that Amy described is for supportive housing providers. So it's entities who are working with individuals with vouchers, either as a voucher administrating agency, which we use to refer to a specific set of organizations, or a supportive housing provider. I think in this conversation, we sort of refer to those two entities interchangeably, but we're talking about folks working with individuals with vouchers. And as you look at that Type 89 certification form, it should answer some of the questions that folks have had about which entities. So hopefully if you review that, it'll be helpful. And I'll drop a link in the chat momentarily.
Thanks, Zach. Appreciate that. I'm going to summarize real quickly because it sounds like Julie had a question, and I know that there's been some back and forth in the chat, but just for anyone who might be listening, the question was for Bernie and Bert. Is there also an assumption that they've already met with a clinician and undergone an assessment, received a diagnosis, and now have a treatment plan? Jennifer said they would not have to have a diagnosis. Julie asked, is it just a treatment plan? And then Jennifer treatment plan would not be needed at this early point. So is there anything else that you want to expand on there, Jennifer, to clarify?
Yeah, thanks. I think in these scenarios, this is early in the process when you're meeting someone coming in. Although a diagnosis is necessary for delivering the healthcare services and having that ongoing clinical engagement, to qualify for the housing service, if you qualify for a housing voucher, that criteria that Zach just dropped, that says this individual qualifies by virtue of their homeless status and they're getting a voucher, means that you would be able to begin your work with them. And in the process of that work with them, there is an expectation that you are going to collect all that information and develop a treatment plan, but you wouldn't need to have that before you could start delivering some of the billable services. So specifically when you're helping someone get connected to these services that they're eligible for, we recognize they won't always have a diagnosis yet.
Thank you. Excuse me. Sorry, I just had a question. It just left me. Sorry, I'll put it in the chat if I think of it. Thank you.
Sure. And I think if there are not additional questions about the scenarios, this is essentially the end, but we do want to point out a bunch of resources here on this slide. So again, since you all, if you know where to get the deck, you can also know where to get to our main landing page, know where to get to our office hours, which is monthly. Amy and Carlos lead that, which is an open space. Show up if you've got a question or you need some help or guidance. It's not a formal presentation. It's just a drop in and get help space. And then additional just details on stuff that we thought would be helpful to you. So just want to call out that those are available to you. And certainly any additional questions that you all have, things we didn't hit on that you were hoping we would, that we can either point you to a resource or answer.
Yeah, HCPF team, Kristen, Jennifer, Amy, thank you so much. This has been incredibly helpful. We do have a couple extra minutes, so I just do want to, to Jennifer's point, check in and see if anyone has any other questions. Feel free to raise your hand, jump in. Happy to kind of take advantage of the team while we've got them.
I think I remember pieces of my question. So like as like a licensed clinician, then you're saying could sign off on on, I guess, these billable notes without any type of connection to like a treatment plan or diagnosis. Like that would be okay with HCPF or with Medicaid.
Yes, we do expect, again, we recognize it takes a little time for someone to come in, so we don't have hard and fast rules. There are kind of reasonable expectations that you're going to need to meet with someone, get them housed, build a relationship to be able to have that more in-depth clinical discussion and get at some of those underlying causes. So roughly, we would assume that in the first several weeks, in the first month that you're working with someone, you're going to get to the point that you're going to figure it out, because you're not going to be able to engage in that clinical care without figuring out a diagnosis, at least a working diagnosis that you're intending to treat, without a treatment plan of how to do it. But we are supportive of a general concept of a housing first approach of like, this individual qualifies, they have a housing need, we know there's other stuff going on, let's get them in and let's have a couple of meetings to get there. Very reasonable. Does that help?
Yeah, no, that's extremely helpful. Thank you so much.
Sure.
There's been lots of kudos in the chat box. So again, thank you, HCPF team. I think this has been incredibly helpful, insightful. I think walking through the process, the scenarios, the different considerations has clearly been really, really helpful. Let me check in again. Does anyone else have any questions? Yeah, Leanne, please jump in.
Thank you. I'm supporting a new team that's coming online with Medicaid, and they have already, it looks like they have established an intermediary, someone's helping broker much of what you're discussing, or clearinghouse is the term, I suppose. And I'm trying to figure out whether or not that's best for them. And so this presentation occurs for me as one that if you prefer to do everything in-house and you've got equipped staff to do it, then you probably should do it in-house, question mark. And then I'm wondering if there is an emerging opportunity in the space for sort of these intermediaries to work between HCPF and the Rays and an agency who's looking to stand up Medicaid. I think the answer to that is maybe that's a new opportunity for consulting. But looking at this presentation, I feel as though you could go either way, but that you all are, though, available to answer any questions by direct contact versus running a message or a question through an intermediary. It seems that you all are accessible to my clients should they have questions, question mark. And so with that, I'll take my seat.
I like to think that we're pretty accessible, and by we I mostly mean Amy and Carlos. I'm moderately accessible. We do use Central, so please don't be put off that we use a centralized mailbox. We do that so that we can support each other and have someone be prompt in getting back rather than you email a person and you have to wait till, they get to your email. So don't be put off by that, but yes, we do try to use office hours. We do try to use central mailbox. We do try to be pretty accessible. We do have a lot of tools and resources. Your organization or an organization you work with may feel comfortable to try this, try working with us, try it on their own first. Can't really give too much advice on that. I see
Sure.
Kristen came on camera, so I want to let her speak to that.
Yeah,
Okay.
I can add for this. There's a number of organizations that do this, that work as we call it like a third party billing or third party administrator.
Yes.
What you see is somewhere between like 5 and 10% they're going to take of your revenue.
Right.
The ROI that the return on investment I would be looking at if I were you is it going to cost me more than 5% of my revenue that I'm getting from Medicaid to operate this internally? In a lot of times for smaller organizations, the amount of time that you spend billing and the amount of skills that you need, it doesn't really warrant like a full-time person.
Right.
So
right.
being able to subsidize that and say, hey, listen, I'm only getting $30,000 a year from Medicaid. That's not enough for me to pay a biller. I want to actually get reimbursed and not spend all my money on the
That
admin.
part.
That can
part.
be really meaningful. So I definitely have found them to be helpful. But
Great.
again, it kind of depends on your organization, but there are a lot of companies. There are large hospitals that use billers. There are small private practices that use them, but they're fairly common. And we're here to help. There's also a number of different ways that providers can ask for help with enrollment as well.
No, that's very helpful. And to your point, yeah, it's small enough that I think it's probably money well spent. By the time you look to pull a function in-house, and we know what the rate's going to be, it's 9%, and then decrements the more that you are collecting. That said, there's a ceiling as to what the org is going to collect. So potentially. So no, that was very helpful. Thank you. With that, I'll take my seat.
Okay, well, I want to again thank Kristen, Jennifer, Amy. I know that there were other HCPF team members behind the scenes helping out. So huge shout out to all of you. Again, we're seeing lots of kudos, and we want to hear from everyone directly about kind of how helpful this was, what else you're interested in. So please consider taking this quick evaluation. It should take about 3 minutes, if less than that, just to kind of get your feedback. And again, as a reminder, we are going to continue to ask you for all of these feedback after the virtual assemblies and the learning circles, because it does help to inform the other topics that we'll be tackling in the future. So definitely please consider filling out the Survey Monkey. Again, it'll take like 2 or 3 minutes and be helpful for learning topics in the future. And then also just want to remind everybody, the slides and the recording will be posted on our resource page, which you see here. We will be posting other upcoming virtual assemblies and learning circles early next week. We will send out an email to let everybody know, but just want to remind you to check that resource page, bookmark it, check it often. We have lots of really exciting things coming up. The next couple of virtual assemblies and learning circles will be continue to focus on funding sustainability. Again, that really comes from all of you, because we have heard loud and clear that this is the top issue that many of you are really focused on, want to learn more about, think more about, and continue to talk with each other about. So you can expect to see this topic for the next couple of months, and then we'll probably start switching gears in October. All right. Again, thanks everyone. We really, really appreciate your time, your commitment, your energy. Thanks again to the HCPF team. And we'll see you all soon. Take care, everyone.
Thanks all.